Record. All right, so welcome to the EDI Grand Rounds today on January 19th. We're welcoming today Melissa Davis. She's assistant professor at Emory Radiology, and she's also the medical director for quality in the radiology department there. She initially earned her BA in chemistry and psychology at Wellesley College, and then her medical degree from the Medical University of South Carolina. She completed diagnostic radiology residency and neuroradiology fellowship at UNC Chapel Hill. And after that, she completed an MBA program combined with an emergency radiology fellowship program at Yale. And it was at that time that I met her in 2018 at the annual meeting of the American Society of Emergency Radiology. She's since joined the emergency radiology section at Emory University. So we are excited to welcome her today to our Grand Rounds, and she will now present on health disparities and driving change.
Thank you. Thank you, Claire, for inviting me. I am going to share my screen here. Great. So good afternoon. I know it's just hitting noon on your side of the country. It's about 3 o'clock on the East Coast. And I really want to thank you for inviting me to speak at the Grand Rounds today. For those of you who don't know me, like Claire said, I'm an assistant professor at Emory in the emergency and trauma imaging group, as well as director of quality. And today we're talking about health disparities and how to drive change. My background is really in operational process improvement, and in many instances, I've been able to tie this improvement work to new technologies in medicine. But health equity is something that I'm also passionate about because I have experienced what poor healthcare looks like. Like many of you, I've had family members suffer from inadequate care and faced with bias in the health system. So although this is not been traditionally the focus of my work, it is something that I'm committed to helping to address within my professional roles. So this talk really is at the intersection of my interest in process improvement and creating equitable health systems. And health equity is a systems problem. And therefore, we need system solutions. And too often, we put people in positions that are supposed to lead the charge on diversity, equity, and inclusion, but we don't empower them with the tools that we would another type of operational leader. We don't empower them with decision-making power, or sustainable budgets for programs and initiatives, or really a seat at the leadership table. And then we wonder why many of our institutions struggle to make progress. So in the next 40 to 45 minutes or so, I'm going to talk about health disparities and change management, and hopefully leave you all with a way to start to think about a sustainable framework for addressing disparities across our field. I have one significant disclosure. I wasn't sure if this was a disclosure or not, but I'll put it in here. I, along with Ephraim Flores from Mass General, co-edited the most recent issue of JACR, which came out last week, and it was focused on health equity. And if you get a chance, please read this issue. We had so many amazing contributions to this work, and more contributions that we couldn't even get into the journal. And honestly, if you don't want to listen to me for the next hour, go read this, and I guarantee you'll come away with many ideas on how to approach health equity within radiology and in our health systems. So this is the structure for today's talk. I'm going to start by looking at what health equity means, and then talk about what change management is and how we define it and measure it. Then we're going to narrow the scope of this talk to specifically looking at some of the work that's being done to address health equity in our field. And finally, I want us to leave feeling empowered to be the arbiters of change. So I'll spend some time here. And I hope that somebody is out there monitoring the chat. If something pops up, feel free to unmute and say, especially if you can't hear me or anything like that. We'll also open up to discussion at the end. When we talk about health disparities, what we're really talking about are our vulnerable populations. So what do we mean when we say, how can we equitably address our vulnerable populations across the United States? Understanding how to approach the conversation of vulnerable patients requires a nuanced understanding of what vulnerability actually means in the context of healthcare. And this ultimately really requires deliberateness and a willingness to really appreciate situational context and environmental context has placed patients in a position that they're not able to fully protect themselves within the care stream. And when I think about vulnerable patients, I really think about my grandfather at the end of his life and the complete reliance he had on healthcare workers and family around him. And I think about the deliberateness that my mother and my family had to embark upon to ensure that his needs did not fall through the cracks as they navigated outpatient appointments and inpatient stays and emergency department visits and long-term care facilities. And often I was dismayed with the knowledge that my grandfather struggled to get appropriate and timely care and was actually harmed by caregivers that demonstrated neglect. And if my grandfather did not have the people in his life with significant experience within the healthcare system, like my mother, he would have struggled even more severely. So addressing our vulnerable populations means developing systems that are deliberate enough not to leave people behind. And I want us to really lean on the idea of deliberate care and providing the care that is needed. The drivers of vulnerability within our health system are complex and often interconnected and include things like socioeconomic status, language barriers, age, mental status, mental health, racial bias, and physical ability as just some of those. The risks of vulnerability are serious. They can range from things from falls to neglect to abuse and in some cases death. And increasingly, research and recent events have really highlighted links between patient vulnerability and our healthcare disparities. And examples of those disparities include the fact that Indigenous and Black mothers are 2 to 3 times more likely to die from pregnancy-related causes than white women, and that number increases to 4 and 5 times that rate after you hit the age of 30. We also see that our rural populations are struggling significantly as rural hospitals close and health systems within rural areas close, and that lack of access becomes an issue. Our veteran population has abysmal cancer screening rates, especially when it comes to lung cancer. There are many, many examples of this within our health system, and it's really created a system of haves and have-nots. But these issues can't be siloed from broader societal conversations on systemic inequities throughout our country, as concepts like socioeconomic status, insurance status, access to care are deeply entwined in our ability to create sustainable living conditions for our population. In August of 2020, this article came out in the New York Times, and the thesis was pretty startling to me, especially the graphical nature that they put this in. And it really showed that decades of housing policies that favored wealthy and white neighborhoods while disfavoring people of color and the poor have led to demonstrable differences in neighborhoods across our country, including clear differences in temperature between neighborhoods as poor and Black neighborhoods were increasingly paved over, creating essentially thermal containers. And white and wealthy neighborhoods are increasingly lined with trees and parks, creating a more palatable and healthier atmosphere. So when we think about health and wellness of our children growing up in a tree-lined neighborhood versus children growing up along smog-filled and loud highways and pavements, and then think about how these populations interact with the health system and the differences in their experience. The point here is that our health is tied to the basic components of our life. So we can focus on the areas that we as healthcare providers have the impact to create positive change. But remember that these conversations cannot be untangled from each other. And this must be something that we consider as we talk about how to create equitable healthcare systems. So we've made a career, as many physicians on here, healthcare workers on here have made a career of taking tests, right? So to prepare for all of these examinations we've taken over the course of our career, most of us have focused on our gaps and trying to close them before the big day. We do this because we know that under stress, gaps become detrimental to performance. And we should have the same thinking when it comes to how we care for our patients and healthcare disparities, and the major gaps for much of our populations and the people that fall through the cracks. And COVID-19 was a prime example of putting stress on an underlying problematic system. And this virus put a severe strain on our system, and those gaps were further exposed. So this pandemic has disproportionately impacted Indigenous, Black, and Hispanic populations. The upside of this disaster for communities of color has been that important conversations were catalyzed about vulnerability of patients with a specific focus on race, socioeconomic status, and class. Unfortunately, we missed the canary in the coal mine, but now that this topic is of interest across society and broader healthcare, we need to dig in and leverage the moment to improve. So there were several studies at the beginning of the pandemic that demonstrated the disproportionate impact of communities of color, namely Black and Hispanic communities, with some studies showing up to 70% of patients hospitalized in certain areas across the country who are Black. This disproportionate impact can be tied back to socioeconomic factors, as we were discussing before. Black and Hispanic communities generally have service professions that put them in the front line, while white and Asian communities are more likely to be able to work from home. This can also be tied to deep inequities in the way that communities of color are treated and managed for chronic diseases such as diabetes and hypertension. So this is the most recent CDC data that I looked at it yesterday. It looks like it was updated in November, but it basically shows that compared to the white population, the American Indian, Black, and Hispanic populations are more likely to be infected, more likely to be hospitalized, and more likely to die from COVID-19. At the same time, these populations have been more detrimentally, while these populations have been more detrimentally impacted by the virus, Black and Hispanic populations are also not getting vaccinated at a rate commensurate to their population density, while white and Asian populations are. And so this dotted line here is really showing what a fair distribution of vaccinations would look like. And we can see that the Black population kind of dips below that line. The white population is tracking right along it. The Asian population goes a bit above, and the Hispanic population is very well below this line. And so we need to focus in these areas to get vaccination rates up within these communities who are also disproportionately frontline workers. This is an article that came out in December and looked at the work of the Black Equity Coalition in Pittsburgh and what they've done to advance the conversation of health equity during the pandemic. And I recommend that you read it. It's maybe like a 10-minute read and really just appreciate the effort that this organization and many like it across the country went through to be able to provide accurate and thoughtful data that really showed the impact of health inequity and the pandemic. So they mapped the location of COVID-19 centers as part of their work and showed that these locations were largely in white and wealthy neighborhoods where many of those residents had shifted to working at home. And then vaccine distribution had the same disproportionate ratio towards these neighborhoods. But the most striking thing to me is that the researchers already really had a sense of where the inequities could be found because they knew their neighborhoods, they were ingrained in their communities. And the data really just confirmed this, but it was really hard to get this data because we often don't track things like race and other factors appropriately within systems that are easily accessible across the country. So their data was layered with census data, labor statistics, as well as zip code data to really drag out what the inequities are. And often we as healthcare leaders make decisions and we leverage data to help us do that. But the lack of data can also hurt us. So I want to leave you with this question to ponder, and maybe we can discuss it at the end of the talk. But when do we decide that as leaders to act on knowledge that we really just know is true? And in instances like this, maybe to ensure that there are adequate testing and vaccination centers in poor and non-white neighborhoods, before we had the data that there's a lack there. And I ask this question because sometimes we're at the decision-making table and we're using lack of data as a reason for inaction, when we are at the table and we actually know, what the data will show. And so what will actually make us move? A lot of what we've talked about over the last 2 years have been health inequities and disparities centered around the COVID-19 pandemic. But remember, this is a systemic problem across all of healthcare. So, PSA screening is lower in Black men, even though the incidence and mortality rate is higher in that population. The research behind prostate cancer largely excludes Black men. We talked earlier about disparities in pregnancy-related morbidity and mortality, and this hasn't really improved greatly for any population in the US, but for the non-Hispanic, Black, American Indian, and Alaska Native women, pregnancy-related mortality is 4 times higher than white, Asian, and Hispanic women. And for women over 30, that gap gets a lot worse, and education does not matter here. So for Black women with at least a college degree, the category that I would fit in, the mortality risk is 5 times higher than that for a white woman. And we even see this trend in lung cancer disease, where we see, early diagnosis. White Americans are more likely to be diagnosed earlier, as well as Asian Americans are more likely to get surgical treatment. But this lack of treatment, Latinos are actually more likely to not get treatment. So we see this disparity among the entirety of our healthcare spectrum. And there are a few articles that I want to recommend to you to read from the current issue of JACR. Dr. De Benedictis' team did a really nice review of health disparities in radiology and looked at a range of vulnerable populations as it pertains to breast cancer screening, lung cancer screening, colorectal screening, emergency imaging, and advanced interventions. And this work around healthcare, the association with rurality in healthcare out of Vanderbilt as well, showed that while all screening for lung cancer in veterans lacks, in rural locations, there's even less access to screening and intervention. We also have a pipeline issue, and this is work done by Christina Chapman and her team in 2014, which shows that there is a need to attract Black and Hispanic applicants to apply to radiology, but also to retain them as residents and to ensure that they become practicing physicians and faculty. These numbers start out low and then they precipitously drop throughout the career continuum. So 2020 was a hard year for us. We witnessed the expansion of a social movement across the country, and many who were not aware of the impact of centuries of systemic racism within our country were seeing it for the first time. And organizations, including many of ours, put out statements denouncing racism and pledging to stand against health inequities and inequities in general. And the masses really were finally convinced of the urgency of this issue, and that really shifted the conversation, and that is progress. And a lot of the work that we have seen in this talk so far has focused on our current state. And the question is, how do we move from our current state into a future ideal state? And where do we go from here? So Maya Angelou is one of my favorite poets, and this is one of her quotes. "We delight in the beauty of the butterfly, but rarely admit the changes it has gone through to achieve that beauty." Now, what do we think this means? Most of us see the final result and the beauty in it, but we don't really ever discuss or appreciate the work and the effort that goes into getting into that final state. We don't appreciate the difficulty of change and the increasing complexity of creating change as we move from individual change to group change to organizational change. And I want to lean on this concept of how can we drive change? And when we see a gap or an issue, where do we go from there to create the final ideal state? And what we're really talking about here is change management. Now that we're here, where do we go? How do we start? So let's start with defining what change management is. So as a definition, change management provides a structured approach for supporting the individuals in your organization to move from your own current states to your own future states. We want to prepare our organizations to enter a period of change, equip them with the right tools to make positive change, and then ensure that they have the support structure to enact and sustain that change. And change management can be very difficult and requires strong leadership in order to be done well. The idea of leaning on business-minded principles in healthcare is not a new one, but has become more important as we think about how our health system has evolved from more independent practices to really large conglomerates. And often we are the largest employers in our cities. We talk about this so much because we, as stated here, leading change is essential and difficult. So we can also help leaders of change by leveraging frameworks to use during the process of change. So there are several models of change in the literature that give insights to leaders about how to think about change and leverage processes to engage in successful and sustainable change. Today, we're going to talk about 3 concepts in this literature that I think can help us start to develop frameworks on how to address systemic racism and health disparity within our organizations. The trans-theoretical model, Plan, Do, Study, Act, which most of us are very familiar with, and then Cotter's 8 steps. So let's start with the trans-theoretical model of change. Trans-theoretical model of change was first proposed in 1983 as a biopsychosocial model of understanding behavioral change. To date, this is most robustly used in addressing addictive behaviors like smoking, with a lot of success. But more recently, this model of change has been used to improve things like screening mammography rates and follow-up. So this model stands on the premise that behavioral change progresses through 6 stages, which are listed here. And so we're going to talk about each of these. And I'll say person when talking about these phases, but you can also think about these as they apply to organizations and groups. So a person in the pre-contemplation phase is characterized as currently not engaging in the target behavior and having no intention to do so. So generally, these people or organizations are not fully informed of the consequences of a behavior action or lack of behavior. And in organizations, these people are often labeled as resistant or unmotivated to implement change. In the contemplation stage, this is characterized as someone who's intending to take an action, usually within the next 6 months, so a relatively short period of time. And in this stage, there's awareness of the pros to making a change. However, the cons still have significant weight. In the preparation stage, this is one in which people are ready to take an action in the near future, generally in the next month. And with this stage, there's a plan of action. So in the healthcare behavioral space, this typically has been things like, I need to join a gym, need to join a group, or implementing some sort of change approach. And then in the action stage, the person is performing the tasks or modifications to implement that change within their behavior or within their organization. And this stage is really observable, like smoking cessation or training sessions. And then in the maintenance stage, the individual is working on preventing relapse. So, but they don't need to apply the mental effort to remember to do the change process as often. So it's really like sustainability. And then the final stage is termination. This is one in which individuals have like no temptation and are confident that their behavior will remain no matter what obstacles they face. Because the behavior is automatic and routines are in place. And although termination is the ultimate goal here, is really not where most of us end up. Most of us end up in the maintenance phase as the ideal state, because things are constantly changing around us, especially when we're talking about how do we sustain efforts to enact changes with our systems that address health disparities. So another component of this model is the idea of decisional balance. And this was conceptualized by Janice and Mann as a balance sheet of cost and benefits, and initially included the constructs listed here. So instrumental to self versus others, approval of self versus others, instrumental cost to self versus others and disapproval of self versus others. We can think about, the discussion that we have had as individuals around masking or vaccinations, or even at an organizational level of requiring masks in our offices and staff to be vaccinated, as the balance of decision making that is happening every day for many of us. So although this model has been largely directed at behaviors, the basic construct of how people and therefore organizations manage change at the behavioral level is not really all that different. So understanding where people are in an organization and where they fit along the stages of change can really allow for a more targeted approach to addressing needed areas of change. And for example, let's take something, relatively simple that I think that all of us have interacted with, the usage of structured reports and standardized reporting. So this has been shown to decrease ambiguity in interpretation of reports that often leads to confusion and medical errors. It also has been shown to promote adherence to guidelines. So there are good reasons to want to institute standardized reporting and standardized templates within systems. But, as there are clear reasons to do that, but at the same time, there are barriers that can be high for radiologists who are not used to standardized reporting. And it may feel that it slows them down or decreases their accuracy or it impedes the way that they communicate. And radiologists at that stage have no intention of moving to standardized reporting and are in the pre-contemplation phase. A radiologist in the contemplation phase is one who understands the benefit of this type of reporting and plans to make some sort of change, however, still has reservations about it. And for radiologists who are in the pre-contemplation or contemplation phases, this scenario requires a lot of data and information directed at this group of people to understand the benefits of making the change. If you're in the preparation phase, this is a radiologist who's engaged in the steps that will allow them to begin to use standardized reporting within their group, and that may be creating templates for the group or giving constructive feedback to the templates that are being put out there. But there really isn't a plan to move that into place. And then in the action phase, this is using the templates for the group as a current practice. And then in the maintenance phase towards determination phase, there's really no reason to go back to a prior mode of operations. And so if an institution wants to implement structured reporting across the department, having an understanding of where the radiologists are along the spectrum is useful for a targeted approach for individual needs in order to get everybody into that frame of mind that we want them to be in. And we can also think about this from an equity standpoint. So thinking about the context of restructuring interviews. A group in the pre-contemplation phase has our residency interviews. In the pre-contemplation phase has no real intention of addressing bias in the interview and selection process. Whereas a group in the contemplation phase understands that there's bias in the way that the interview candidates are selected, interviewed, or ranked. And they're getting that because they understand the information, the data that's been presented to them that allows them to move along these phases. A group in the preparation phase is actively engaging in steps to mitigate or address the bias by instituting new selection processes, standardizing or blinding interviews, or instituting training for interviewers and selection committee, looking at bias training and things like that. A group in the action phase has these things in place and is iteratively improving on them so that they can move them into the maintenance phase where most of us tend to be once we've enacted change programs like this. And we continue to be in the maintenance phase, usually indefinitely. So let's talk about Plan, Do, Study, Act. This model is widely used in healthcare and quality improvement, and most of us have leveraged this in one way or another. PDSA is a systematic cycle for building knowledge and implementing a continuous change process. And the strength of this is that it's really a scientific method, which a lot of us are very comfortable with, modeling hypotheses, data collection, analyzing and interpreting the results, and then iteratively changing to improve on that. So this was originally created for industry outside of healthcare, but was translated into healthcare in the mid-90s by a guy named Gerald Langley. In this adaptation, plan is characterized by identifying the objective and resources to carry out a cycle. And those resources can be financial, human resources, structural resources, and system resources. And I'm going to lean in on the fact that resources include financial resources, human resources, structural resources, and system resources, because too often we under-resource our diversity, equity, and inclusion efforts and then wonder why they don't succeed. So this is very important. The do entails executing the plan and documenting issues and observations. Study involves data analysis and comparing the data to your initial hypothesis. And then act being the process of reiterating on that project. And thinking about this as a continual cycle of improvement that's done repeatedly over time. As a predecessor to the PDSA cycle, this is the model for improvement, and the model for improvement interjects 3 questions at the initiation of the cycle. What are we trying to accomplish? How will we know that the change is important? And what changes can we make that will result in improvement? So I want to spend the rest of this talk looking at Kotter's 8 steps of change. And I really like thinking about change in this way because it looks at the organizational responsibility to ensure that change not only happens, but is sustainable. And in my experience, sustainability is really the hardest part here. So in 1996, John Kotter, who is a Harvard Business School professor, wrote a book called Leading Change and introduced the 8 model step of change, which he developed after researching about 100 organizations which were going through change processes. And so he lays out these 8 steps. The first is establishing a sense of urgency. And I think a lot of us saw that sense of urgency in 2020 and that continued push that happens today. So now we're at a point where we've identified a crisis and we see the opportunity. Forming a powerful guiding coalition. When we think about forming a guiding coalition, this is a group with enough power to actually lead change effort because they can make decisions or they have the financial wherewithal in order to be able to do that. And then encouraging this group to work together as a team. And it's up to them to really create the vision of where we want to go as an organization. And that vision has to be specific and intentional. And there has to be a way to develop strategies to actually achieve that vision. And then most importantly, you have to be able to communicate that vision throughout the organization. And this has to be done in multiple ways, either email, town halls, conferences, publications, whatever we can think, because people communicate in different ways. And so we also need to lead by example and communicate by example. If this is the way that we want our organization to move, this is the way that our leaders have to lead as well. And then we have, for the 5th step, thinking about empowering others to act on that vision. So how do we empower our entire organization to act on the vision that we've set forth? And that means you have to get rid of obstacles to change. You have to remove the structures that undermine your vision. And then encourage non-traditional paths within the organization to tackle issues going forward. This is followed by planning and creating for short-term wins. A lot of times when we look at things like how do we address disparity across our system, that is a big project. That's not something that we can turn around, on a dime. But if we don't create short-term wins and short-term goals from that big goal, you're really actually going to disempower the staff to keep moving forward on it because they're going to feel like they're not winning at all. They're not getting to the next improvement. And studies have shown that people who see short-term gains or can be celebrated or recognized or rewarded for short-term improvements will continue on those improvements so that you eventually get to the long-term goal. And then 7 is consolidating those improvements. And that really means thinking about your structures and your system more. So what are the policies that don't fit in this vision? How do we restructure them? How are we hiring? How are we promoting? How are we developing our employees? Do we have a pathway to sustain the work that we've done? Because this is really what the organization is now. And that leads to institutionalizing the new approach. This is what the organization is. We have to be very explicit in that and articulating how this correlates with success of the organization as a whole, and ensure that our leadership through successive years continues to promote that in the way, and that's really the way that they are developed. So like I said, of the models I've discussed, I think this is one of the most comprehensive ones, and it really hones in the fact that you need strong leadership to really create the space for change to occur. So let's switch gears a little bit. We've spent time looking at what is change and some frameworks to create and sustain change, but how do we know that we're going to be successful at it? So we have to be able to measure change so that we can first prove it, but more importantly, that we can message it throughout our organization. So I'm going to go and spend a little bit of time on measurement. So there are three basic types of measures: structural measures, process measures, and outcome measures. And so we'll take a look at each of these. A structural measure indicates the capacity of a system and process. So in other words, structural measures ask the question, do you have the components you need in order to have an effective system? And these include, in the context of DEI work, is there a committee around this? Do we have a leader in place around this? Is there programming? Is there budget for it? Things like that. Process measures indicate what we do to maintain or improve. So in other words, how are we driving improvements? And these, I think, are the most important measures because they allow us to focus on the use of best practices. They also help us with the implementation and improvement strategies. And when things go wrong, they can help us understand the root cause of why things are going wrong. So examples of this include tracking the percent of people who obtain screening mammograms in a practice or who undergo conservative management for back pain before imaging. These metrics are just numbers, but really behind them are the questions: why are we, what was it that we're trying to actually change? What is it that we're trying to drive? And when we don't meet those internal benchmarks, why are we not doing that? And we can take a deep dive into our organizational processes at that point to find the answer and make those improvements. And when we think about disparities, we can think about measures like the percentage of DEI training is completed. Did our selection committee go through this 100%? If not, why not? Accessing tools and modules, are they being used within our department? Why or why not? And understanding things like leader standard work. How much of us actually have that as leaders across the department? So an outcomes measure indicates the impact of an intervention. So if you come to this place or go through this process, how will you be on the other side of that? And examples of this include your hiring rates, retention rates, how many patients return for repeat services, and things like promotion rates. For more information on understanding key performance indicators, I would recommend that you look at this article. This is by Dr. Lane Donnelly. He's the chief of quality at Stanford Children's Health. And he wrote a nice article about how to leverage KPIs when looking at health equity specifically. I truly believe that we need to consider DEI efforts as organizational change efforts. And until we see them as part of every leader's job, not just the vice chair or dean of diversity's job, we won't make the progress that we actually strive for, because these roles are historically chronically under-resourced and lack the appropriate power structure to actually improve significantly. So this is a paper that I wrote with Sydney Dupree. She's a professor at the Yale School of Business who focuses on social and behavioral change, and Dr. Carolyn Meltzer, who has been a champion for diversity and really needs no introduction, but she's our outgoing chair at Emory, and has done a lot of work in advancing diversity across our field. And in this article, we provide a framework for understanding DEI efforts as organizational change management efforts and how to specifically address racial gaps in radiology. So this framework includes things like goal setting. So like we mentioned in Cotter's 8 steps, we need to be able to articulate what our vision is, and this must be specific and intentional, and it has to address the drivers of inequality within healthcare. Norm setting, when we talk about norm setting, we talk about how do we have conversations. So diversity without inclusion is still a problem, right? Merely diversifying an organization without addressing the underlying issues is almost a fruitless endeavor. We have to be able to have difficult conversations about our organizational barriers if we're actually going to address them. And we have to learn how to have these conversations productively at all levels. And that's really the hardest part, is learning how to have a conversation. Incentivization. We often center rewards around financial achievements, so productivity, RVUs, volume, things like that. But focusing on this can actually demotivate from addressing issues of care around our system, and bringing in the focus metrics that can reveal inequities as targets for incentives is also important. So thinking about metrics that look at belonging and engagement and promotion rates, and tying leaders' accountability to those as well as the productivity rates. Tools, we spoke about, some of the tools that we can use for change management, especially along those frameworks that we've looked at before, but also looking at things like surveys and town halls and feedback sessions and things like that, so you can start to understand what is happening within your organization. And finally, metrics. Metrics are very important. It's important for us to be very transparent about what's happening within our organization. So being thoughtful about how we're tracking and how we leverage metrics to dig into issues around our organization allows us to notice those gaps. And we have to be looking for the gaps in order to improve them. Otherwise, they're just always going to be there, and we won't be looking to make things better. So I've been particularly impressed with the work that Emory Radiology has done to improve DEI efforts. And I think it shows in the type of talent that the department's been able to attract. There are several other departments, radiology departments, and people in radiology who are doing this work. And my advice to you is really to reach out to them, to learn and to collaborate on this journey. So I'm going to close by going back to Maya Angelou. The reason that we engage in change is because we ourselves are always evolving, and our knowledge and our tools are evolving, and we really have a duty to ensure that we give our patients proper care and that we have a healthy future and work environment for all of us. And a lot of us are also change agents because we know that something just isn't right in our environments, and that impacts our patients, our staffs, and our providers. And we all inherently know that there are better organizational processes that we can engage in order to improve the way that we practice medicine. But engaging in that conversation and being somebody who wants to see change will always be an uphill battle. And so for ourselves, we need to decide if we're willing to engage in that work or not. And I really think that that's the quote that's the kind of the meaning behind the quote that Maya Angelou put out here. And then know that if we're going to engage in that, that is good work, that it is rewarding work, and that is very impactful. Many of us get overwhelmed on how to even start. And my advice to you is to start small, pick a narrow area and test the change process. And then leverage the frameworks that we discussed earlier and grow from there, because we really need people to work on this at all levels and all positions within the organization in order to continuously improve. And remember that this is not work for the marginalized community. This is work. This is all of our work that we have to do. So with that, I want to say thank you It's been a real honor to be invited to give grand rounds at the University of Washington. And I'm happy to open the floor discussion. I'm also happy to chat more offline. My email address is here. You can also tweet at me if you wish. So, thank you.
Thank you so much, Melissa. Are there any questions out in the audience?
I have a question. Thanks so much for that. This is a fantastic presentation. I like all the Maya Angelou references. I think she recently became the first Black female on a U.S. quarter, which I just heard about recently. I thought that was pretty neat. I had a question regarding in terms of your models, the models of change that were presented. The trans theoretical model of change. The Cotter's 8 steps. I was kind of curious to get your thoughts on how do some of these models of change in terms of incorporating radiology diversity initiatives and how that process works, or how these initiatives apply within these models of change. One of the things that I think, as you mentioned, I think in the last couple of years, we've seen a lot of efforts to sort of focus more attention, and I think very appropriately so. I guess what I wonder is that sometimes, let's take the trans theoretical model of change. There's the pre-contemplation phase, the contemplation phase. I think it's the preparation phase, and then the action phase. Out of those, and out of those 6 steps, I think it's happened such that we've been very focused on trying to make sure we've got processes in place in order to address these obvious deficits. And so I think a lot of that time, that at least what I think is that the preparation phase, let's say contemplation phase, have tended to be a little accelerated, and we haven't yet seen maybe what some of the outcome measures can and will be. I'm sure we will in a few years. Similar with Cotter's 8 steps, where I think we've done a great job in radiology and diversity efforts. And I should say, it's not just specific to radiology and diversity efforts, right? We're seeing this in all sorts of industries. We're doing a good job at creating a sense of urgency. I think in many organizations, we've got a good coalition of team members. And in many cases, we've been able to, and I think Emory is a good example, I've been able to clearly articulate a vision. And it's just hard. I'm just curious to see, with an accelerated time frame on a lot of those important preparation stages, like the P and the PDSA, what are we going to see in 5 years? I hope to think we're going to have fantastic outcomes. It's hard to know, just given the more, I think, the shorter time frame a lot of the organizations have been working on.
Yeah, no, I think that's actually a really good point. A lot of this, there was a lot of quick work that has been done, and I think that at the end of the day, you're going to see where people stop and said, what is it that we're actually trying to do? Like, what is the change that we're actually trying to make here? And thought about, okay, if this is the thing, how do we know that we're successful? And put that framework in place first before actually implementing the change. You're going to see outcomes there probably be better than maybe implementations that were like, we just got to do something. We just got to stand something up, because that thoughtfulness in the initiation of that program, or of those things that are being put into place, is actually probably the most important part here. And like you said, the metrics, we have to know what exactly is it that we want to change. We have to know how we're going to be successful. We have to know what actually matters. So a lot of times people put things into place, and the people that they're supposed to impact, they're actually like, this doesn't actually matter to me, like this thing that we put into place. So I think that we all, even when you're trying to do things fast, you have to take that initial step of saying, what is it? Why is it? How are we going to say this is successful or not?
Yeah,
Dr. Davis, this is, oh, sorry, Ramesh, go ahead.
I was just saying, I totally agree with that. Sorry, I didn't mean to interrupt.
No, thank you. It's a great question. Good discussion. Dr. Davis, I'm Tess Chapman. I'm the program director for the residency. And so I was curious if you can share with me any examples that you've seen at Emory involving the residents in these efforts to address healthcare disparities. I think residents, understandably, they are on a short course with a variety of different challenges in front of them, and they might have their own personal objectives, et cetera, and there's always hard work to do. And so it can be intimidating for them to get involved in some of these efforts. Do you have any examples of kind of short-term projects that your residents have been involved in?
I mean, so we have a wellness committee here and a diversity committee as well, and we have our residents involved in that. And usually, you know, the projects that they are most attuned to are the ones that are going to help them specifically, like help their lives be better, especially for like the next round of residents that come through. I think a lot of the times we have our residents kind of involved in some of the research that we do around diversity, equity, and inclusion. I'm just gonna like promote another article that's in the JACR issue where we had residents on a paper that looked at staffing across our centers, our health systems. So we have multiple health systems, or multiple hospitals at Emory, and they all kind of serve different types of communities. We have a huge level 1 trauma center here, and you know, we notice on a day-to-day when I'm sitting in the reading room, like our staffing's not great at the level 1 trauma center, which disproportionately serves the poor and marginalized within our community. So, and our residents feel that as well, because there's no attending like in-house overnight and things like that. So the first piece of that our residents helped us do was to look at acuity across all the hospitals. And obviously we saw that the acuity was highest at the trauma center, and then compare that to staffing across the hospitals. Right. And that really leads us into a conversation of, are we staffing appropriately?
Thanks for that. That's great. Yeah, lots of work to be done. It really is the focus of your talk. It's great to have you here. Thanks.
Thank you.
Hey, Melissa, this is Christoph Lee. Great presentation. I think you guys at Emory are way ahead of us in regard to moving along your Carter's 8 steps. And I'm wondering where you feel like you are as an institution on the Carter's 8 steps. Have you gotten your entire department to commit to a vision? Has the vice chair of EDI and you and others on the committees been able to clarify a plan of action and have clear outcomes? And if you could, maybe share some of those early win outcomes with us.
Yeah, I think, so I think as a department, we're doing really well. I think we had strong leadership in this realm. So like I said, Carolyn Meltzer is very well known for her push on diversity efforts, and she's infused that throughout the radiology department at Emory. I think I mentioned before that a lot of times when we put people in places like vice chairs of diversity, we don't give them the resources in order for them to actually be successful. They end up kind of being more influencers than people with sustainable power. And in the way that she has set it up, her executive committee, that person has a real voice at the table. And I think that things like that have allowed Emory to really progress, further than a lot of other organizations, but there's still a lot of work to be done. There's still a lot of gaps that are here. And I think that it's been largely focused within the radiology department because of that specific leadership. But when you look at Greater Emory University, there is so much more that can happen or that needs to happen. And you don't really feel that impact as much. I forgot what the second part of your question was, Chris.
If you could share some of the short-term goals or outcomes.
Oh yeah, so Amari Johnson is our vice chair of diversity, and he has really looked at things like hiring and retention rates as maintaining, and at the residency level, looking at ensuring that we have a nice swath of diversity throughout the residency, as well as the types of who we interview, things like that. So I think the major metrics that we have are really around hiring and retention. And you can actually see that, I think, in the makeup of our division. Amari also happened to be the division section chief for emergency and trauma imaging, and the diversity within our section is on all levels: race, identity, sexual orientation is I think pretty good, and I think that's because we have some people who have really pushed that.
So,
Thank you.
Dr. Davis, this is Sudhakar Pipavath. Thank you for a wonderful talk. I have a small goal that I want to set for our department. We want to increase our Black faculty recruitment within our department. Can you give us some sense as to how to make that change? I know you gave us this. At what level do you think the change starts? Do you think it should come? It should be on the agenda from the chair level almost each and every time, or this is an open-ended question. And if you look at, I've been here since 2006, and I can't think of a single Black faculty member who's been in our department. And so I'm just wondering, we all seem to do these activities, but we never seem to make stride in that particular direction. Do you have any experiences or suggestions for us as a department?
Yeah, I mean, I'm not going to tell the chair what to do at all. But I think it has to be on the agenda, right? Like maybe not every time, but it has to be something that from a leadership level, you say, hey, this is important to us. And I think we have to set goals around that. If you want to increase that percentage by, 100% or whatever, so I have, 1 or 2 or, over a certain time span, I think it's important to have goals, but it's also important to have time around those goals. Like, when do you want them actually met? And then I think that the effort comes from like a multifaceted view. I think getting back to the residents, who are we selecting as residents? Are we ensuring that our residency pool is diverse? Because a lot of times, though, you can attract residents to stay in your program if they feel like they had an inclusive environment that supported them throughout their residency, and they want to continue on within this space. You also have to look at, how do we actually reach out to applicants? Are we, a lot of people just post something like on the ACR job board, but are you reaching out to organizations like NMA, for example, which has a large group of Black radiologists within our organization? Are we using kind of a word of mouth approach, which is often a lot more impactful than kind of just like posting something on a job board? And then when people come to interview, how do they feel during the interview day? Like, do they feel welcome, or they feel like they're going to be kind of the sore thumb or the tokenized one? Because a lot of us are not going to want to be in a place where we feel like that's the case. And honestly, when you get one person who really enjoys their experience, it'll be easier to get the next person. And I think you can look at Emory as the example. There are several Black radiologists in that department, but it's because we recruit each other almost a lot of the time. I say, like, this is a great environment to be in. And so you have to ensure that you have that environment that people want to stay and thrive in.
I stand slightly corrected. We did have Dr. Akim Pelu, who's one of our faculty members in emergency radiology. But for me, we had such a rich experience with him that I still think of him as our resident. So we have such good bonding. So I think we do have one faculty. So we did move slightly forward. Hopefully we'll see more and more. Thank you.
Ramesh, if I just have both question and a comment. First comment, this fantastic presentation, Dr. Davis. You really provided a lot of insight and shared your successes and also approach how one can bring change management in the system. And of course, the one point I feel is critical is it should be a cultural change. for this to be sustainable, for this to scale up by itself, it has to be a cultural change across the department or health system. And I think you rightly mentioned, if we bring in trainees who are underrepresented in medicine, it's all about the environment we provide where they want to stay back. And our job is to create that environment, nurture them, mentor them. So we have one success in recruiting Black faculty. We are working with another trainee, and hopefully we will be successful here. But I think this is a journey. And one needs to commit to this journey and bring in meaningful changes. And I'm truly fortunate. We have many members in the department who are committed to this mission and bringing those changes. My question to you is, this you have probably indirectly addressed that. Was there any one single approach or a change you brought that was most impactful?
That I brought into
the department?
Yeah, I think if I could say like one impactful change that like I have personally brought into the department, I think it's you know, since finishing my training and having my first faculty job, now having my second faculty job here at Emory, it's, you know, I've had a lot of opportunity, and that opportunity has allowed me to be able to be, you know, slightly known across the country, to be able to attract Black radiology residents who reach out to me and say, hey, you know, this is what I'm going through here. These are the questions that I have. Or even med students. A lot of med students reach out and say, can we have a conversation? And I think that, you know, the ability to be able to mentor them, either through like the hardships of residency, which are a lot, or to be able to understand like what are the things that I need to do to be a competitive applicant within radiology, so that I get out there and succeed. To me, like that's been the most gratifying part of all the work that I've done, kind of beyond anything else.
Thank you. And I think that building that pipeline mentorship is so critical in this space, and having a role model like you really make all the difference. So thank you so much for sharing your experience, your leadership, and expertise in this space.
Thank you.
I would defer to Claire for closing comments.
Oh dear. Well, if there's no more discussion, we can certainly wrap up. And again, Melissa, thank you so much for the presentation and for the engaging conversation afterwards. And hopefully we can do some cross-departmental fertilization in the future with ideas.
Definitely. Thank you so much for having me.
Absolutely.
Thank you very much, Melissa.